Um, so evidence-based treatments, are we improving outcomes and which treatments help? Perthes disease is now more than a century old in terms of our knowledge of Perthes disease, and we all know it as the idiopathic avascular necrosis of the capital femoral epiphysis in children. In spite of over 100 years, what do we have in terms of evidence as far as the treatments are concerned? We know that the head remains biologically plastic after an episode of avascularity or infarction, and this plasticity remains for a long period of time, maybe about 2 years of time. This is from the work of Salter. The head is at risk for flattening and extrusion during this healing phase. Because it's plastic, it is under risk for flattening and extrusion, and this happens during the healing phase or revascularization phase. Now, what are the management goals in Legg-Calve-Perthes disease? Based on this pathogenesis, what we want to achieve is a spherical femoral head. We want to prevent coxa magna. We want to maintain the femoral neck length if that is possible. We want a normal neck shaft angle, and we want a normal articulo-trochanteric distance. So these are our aims in managing Legg-Calve-Perthes disease. The prognosis is governed, how well we have managed is defined by the prognosis, and that is governed by the Stulberg classification. The 1 and 2, fairly spherical and congruent. The 3 and 4, aspherical but congruent. And 5, aspherical but incongruent. So let's come to the proper heart of the lecture. What is the evidence to say that treatment makes a difference? Do we have any evidence? Well, the treatments are available. There are non-surgical treatments and there are surgical treatments, but we know today that these treatments are governed by several factors. Just to name a few, age at clinical onset is a very important variable. The younger children have a good prognosis and may demand no treatment. Extent of capital femoral epiphyseal involvement, how much of the epiphysis is involved? Is it less than 50%? Is it more than 50%? I think is an important parameter. Stage of the disease in terms of Elizabethtown classification, how late are we in the course of the disease will determine the prognosis with treatment. And then the deformity, established deformity of the femoral head and acetabular at diagnosis. So there are so many important variables, and this was not realized till very recently. And that is why almost all studies which date back to maybe more than a decade ago in the past, or maybe 1990s, have limitations. Generally, they have been smaller series. They talk of 15, 20, 30 patients, so that there's no power really to that study. They have been heterogeneous studies. They mixed up all sorts of age groups. They lack prospective randomization, and there is the absence of skeletal age in most considerations. So there are limitations of the studies that we see in the literature. So where is the proof? So what is the evidence to say that non-surgical treatment makes a difference? As we said, there are two forms of treatment, non-surgical and surgical. So is there any proof to say that non-surgical treatment makes a difference? Non-surgical treatment, again, there has been a spectrum of this, right from no weight bearing in the early days to prolonged immobilization. Joint mobilization was then proposed, weight relieving orthotics, non-ambulatory containment, and ambulatory orthotics and containment. So we have a variety of techniques by which we effect a non-surgical management in Perthes. There are a lot of advantages to non-surgical treatment, largely that of being non-invasive. However, there are a lot of disadvantages too in terms of the long treatment time and problems of compliance and stress in the family. What are the results? Going by the past results which have been quoted, without containment, the results have been poor, 30% poor results, as shown the slide on your on the left column of poor results. And containment, if you have containment, then an average of 12% bad results. But you have to remember these are older series and really don't follow the rigor of scientific inquiry. More recent series in the 1990s, and 2 papers came out on the weight-bearing abduction brace for managing Legg-Perthes disease. And this one was by Martinez, 31 patients with more than 50% involvement of the capital femoral epiphysis, managed with the Atlanta Scottish Rite, an abduction type of orthosis with weight bearing. None of the hips had a good result at a mean follow-up of 7 years. 65% were classified as poor. They concluded that severely involved hips should not be treated with a weight-bearing abduction brace. Same year, another study came out by Meehan, and the conclusions were really the same. In fact, the percentage of poor results is also the same, 65% poor results. The authors felt that the weight-bearing abduction orthosis offered no advantage compared with other methods of management or with no treatment in more deformed hips. 2004, this was the only prospective multicenter study on the effects of treatment on outcome by the group by Herring, and they studied the outcome in 345 affected hips. They divided them into 5 treatment groups consisting of no treatment, range of motion exercises, brace treatment, femoral osteotomy, and innominate osteotomy. And they concluded, and they had a very good statistical backing because of the large number of cases which were there. The conclusion was that no differences in outcome among the hips with no treatment, those treated with bracing, and those treated with range of motion therapy. So even those treated with bracing were equivalent to those who had had no treatment or who were treated with just physiotherapy. Very recent publication this month actually, September 2011, and I was hoping Mr. Thompson would be here, on the role of bracing in Legg-Calve-Perthes disease. They reviewed the whole literature of bracing in Legg-Calve-Perthes disease, and they came to the conclusion, this particular group came to the conclusion, that the present literature does not provide evidence sufficient to support the use of bracing in Legg-Calve-Perthes disease. On the basis of this review, our recommendation is that the abduction orthosis should rarely be used in the treatment of Legg-Calve-Perthes disease. Now we come to surgery. Then what is the evidence to say that surgery is beneficial in this disorder? Well, again, the evidence comes from this multicenter, prospective multicenter trial by Herring, and they came to the conclusion, this was more than 350 hips nearly, patients over the age of 8 years at onset with a lateral pillar B or BC border group have a better outcome with surgical treatment. So there were different groups, and there were groups which had no treatment, there were groups which had surgery, and in the surgical group, they had those treated by femoral osteotomies and those treated by innominate osteotomies, and their conclusion that patients over the age of 8 years at onset with a lateral pillar B or BC border group have a better outcome with surgical treatment. Type C cases often have poor results despite treatment, and children less than 8 years of age, they made the statement, and definitely less than 6 years of age, really there's no difference between surgical treatment and no treatment. I mean, they don't need any treatment. The results are as good without treatment as with treatment. Surgical methods most predictable in the Dallas study. The conclusions, type B is helped by surgery. Type C, there is no benefit, but they studied only the simpler containment methods, femoral osteotomy and Salter osteotomy. So which surgery? What is the evidence for which surgery, femoral versus acetabular? Which should we be doing? Surgical containment was translated in terms of a femoral varus osteotomy very early. However, larger series came up from the work of Sorrell, Axer, and Lloyd Roberts and Tony Cattrall. And in 1976, Lloyd Roberts and Cattrall wrote on the indications for and the results of femoral osteotomy in Perthes disease. Varus osteotomy gives a good result, and you can see this case here with a more than 3 years follow-up. A badly fragmented femoral epiphysis with extrusion, and the end result after a varus osteotomy. However, the results of this prospective multicenter study, the conclusion was that when you take the osteotomies, whether it's a femoral osteotomy or an innominate osteotomy, treatment is beneficial. Surgical treatment is beneficial, especially in the group B and BC. But as far as the technique of surgery, whether you do a femoral varus osteotomy or you do an innominate osteotomy, it doesn't seem to make any difference. In 2008, WIG, from a multicenter study, this is the next multicenter study from Norway, and they enrolled 28 hospitals in Norway. They took patients over 6 years of age with more than 50% necrosis, that's Cattrall 3 and 4, and they assigned them to 3 methods of treatment: physiotherapy, abduction orthosis, and proximal femoral varus osteotomy, 71 patients. Their conclusions: in children over 6 years of age at diagnosis with more than 50% femoral head necrosis, proximal femoral varus osteotomy yielded a significantly better outcome than orthosis or physiotherapy. So here is more support for surgery, especially in children more than 6 years of age who have more than 50% femoral head involvement. They recommended this sort of osteotomy in children aged 6 years and over at the time of diagnosis, with hips having more than 50% femoral head necrosis. They also had the group which had abduction bracing, and they concluded, because the results were uniformly poor, they said that this should be abandoned in Perthes disease. As far as innominate osteotomy, the evidence comes from Salter's paper in 1984. They compared non-operative management with managing patients surgically with the innominate osteotomy. The innominate osteotomy group had 6% poor results. The non-operative management group had 34% poor results. So this is Salter's osteotomy for Perthes, and it's quite well known to most people. In older children also, you could do a Salter's or a other form of osteotomy, which is a triple type of osteotomy. There are other series which support the work of Salter. So Salter and Brown, 1988, and coming down to 2005, Kitakoji. Most of them quote a fairly good result with the innominate osteotomy for Perthes disease with severe head involvement. Now what about combined pelvic and femoral osteotomy? In the older child, in very severe involvement, there are inherent limitations of doing a femoral osteotomy or a Salter's procedure, because you really cannot contain the head fully with a Salter's procedure in that age group. And that is why a combination treatment arose between pelvic and femoral osteotomy way back in 1985, only in Asher and Crutcher and Staheli, and then the last papers to last year. In fact, there are more papers, but Vukasinovic in 2009. These papers quoted an improvement vis-a-vis the natural history. Also, improvement of femoral head sphericity was found with growth. So this is Staheli's paper on combined osteotomy, Varus osteotomy and the innominate procedure for Perthes. And an example here: severe involvement, extrusion, post-surgery, Salter's and femoral osteotomy. This is over a year follow-up. And at the age of 11, this is 4 years follow-up. You see that the head has remodeled very spherically. The last thing I want to touch upon is advanced containment methods for Legg-Calve-Perthes disease and results of triple pelvic osteotomy. Now it was found that if you do Salter's procedure, in some of these cases, it's difficult to get a containment, especially because you tend to get some sorts of impingement in these cases. And that is why triple pelvic osteotomy actually frees the acetabulum much better, so that you are able to cover the femoral head very well. They had 40 hips. Again, this study has just come, this came in December 2010. 40 hips in 39 patients with a 3-year minimum follow-up. 4 patients of this group required further reconstructive surgery. So severe involvement. However, nearly 89% fared to good results, so that you could improve the results of management by using advanced techniques of containment like triple for certain types of cases which may not be amenable to doing just a Salter's procedure. So this is 39 out of 40 hips were pain-free, 5 patients had a mild limb, and no significant limb length discrepancy. So sequence pre-op, this is pre-op on the MRI, and containment with a triple osteotomy, 7 years post-operative. So a meta-analysis of all that I have been saying: surgical intervention for containment, we know that it helps. The conclusion of this sort of a meta-analysis, and this is very important: patients undergoing containment with a femoral osteotomy or a Salter innominate osteotomy during or before fragmentation phase have better femoral head sphericity at the end stage of Perthes than those undergoing non-operative intervention. So this is very, very clear. The data suggests that surgical intervention improves femoral head sphericity. To summarize, surgical containment is useful. Femoral osteotomy for the simplest cases of young children. Salter's osteotomy can also be used for routine cases. harder to do. Be careful about retroversion and impingement. And for the older children with more severe Perthes, older cases B, C or C category, heading C, Salter and Varus, or triple osteotomies, triple pelvic osteotomies. So I thank you very much for your attention. This was just touching the evidence base. What do we have in the literature today as far as Perthes disease is concerned? There are areas we still don't have enough. For example, arthrodiatesis, for example, hip arthroscopy, or biological forms of treatment and some other forms of treatment. We don't have enough data. But fortunately, now that we know the variable parameters, the study designing is better, and we should have some data on efficacy of treatment methodology in managing Perthes disease in the years to come. Thank you very much for your attention.
Thank you very much, Dr. Johari, for this overview, which is now open for your questions, remarks.
Absolute indication for triple osteotomy.
I think it's more in grown-up children where Salters could be very difficult, and you probably not able to contain that fully, So, as you mentioned, grown-up children, maybe more beyond the age of 11, 12, 10, 11, 12, that age group with a severe involvement, so that you are able.
We should not do Varus osteotomy.
You may combine it. If you get a containment, then there is nothing really. You don't need to do a Varus osteotomy.
Varus, or we should go for
Varus osteotomy in that age group has problems because it doesn't remodel, so that you are left with a permanent coxa vara. At the age of 11, 12, there won't be remodeling because remodeling is only up to the age of about 14, and
so
with
8 is required triple osteotomy.
problem of avascularity, remodeling also is poor, so those cases you require triple osteotomies. Please.
For the femoral osteotomy, it is easy to make abduction pin to 90 degrees. How much Varus should I take? How can I? For the proximal femoral osteotomy, there is abduction fin to control the amount of Varus. How much should I obtain? How can we control the triple osteotomy to ensure adequate containment with adequate coverage without retroversion?
Yes, in most of the cases you need about 25 to 35 degrees of Varus, so somewhere around 30 degrees of Varus is required in most of the cases, But if you want to be very precise, you could do an arthrogram intraoperatively. You could do an arthrogram and check the containment.
Yeah, Ashok, you review those literatures, and the problem of evidence-based. Morpori's statistic in meta-analysis has a big problem, is heterogeneity. Because the paper are not written in the same fashion, same good study with a group or randomized trial or trial type of study. So put all the series together, the heterogeneity is a problem. Try to do a good meta-analysis.
That is true, That is what I mentioned earlier, so that the real scientific work has actually just started now, That's the problem, we lost nearly 90 years, in actually coming to the study design. The problem has been of design.
Any more questions? Thank you very much.